Um, Olivia and Hannah Ruth, this is Dr. Miller. Um, my name is Mr. Hershko. You and I, we all spoke by email, but we've never actually met before. My goal for this is simply to you guys interact with a medical professional, have him talk to you about what his practice is about and how he got where he is now, and then really to have right now, three of you have a chat about what medicine is and what interests you have, and recording the entire thing the whole time, and then we'll upload it later for other kids. So, having said that, why don't you two introduce yourselves and let Dr. Miller know what your name is, what school you go to, and what grade you're in. Go ahead.
I'm Amanda Sinclair. I'm 17 years old. I go to the Taft School in Connecticut. It's a boarding school, and I'm currently a senior.
Okay.
Uh,
Hannah Ruth.
I'm a sophomore at Westminster in Atlanta, Georgia.
Okay.
Great.
Amanda, you should know I teach at Brunswick in
wow.
Greenwich, and Dr. Miller's in Greenwich right now. So we're all in Connecticut, except, of course, Hannah Ruth. Okay. All right. So I'm going to move to full screen and start recording. You guys go ahead. Dr. Miller, the show is yours.
Great. So Hannah and Amanda, it's very nice to meet you guys. And we don't have anyone else on the line at the moment. Is that right?
That's correct. I'm going to try in a few minutes to find other kids.
Okay. So, do you either of you have, I assume you have some interest in medicine at this point, or you're not sure yet?
Definitely sure about Yes.
Okay. So I thought it'd be interesting tonight just to give you a little background about orthopedic surgery, how I got into it, what I do every day, and what I think of it as a field, and talk a little bit about medicine as a career. And then I'm happy, I'll speak for a while, and then I'm happy to answer questions that you guys may have after hearing all this information, okay? Orthopedic surgery as a field within medicine, I think, is a fantastic specialty within the medical career. When you choose medicine as a career, there's a certain commonality in that when you want to be a doctor, I think you have an interest in science, you have an interest in people, and an interest hopefully in making people's lives better and in helping people as a career. But after you make that choice, within the world of medicine, there are many different specialties, and each specialty as a career choice is quite different. Orthopedic surgery, which is the study of muscles, tendons, ligaments, and joints, is a field that I got into a little bit late in my medical career. And I was involved with sports, and I played soccer both in high school and in college. And I was very involved with multiple sports, and that was always important to me. But when I got to medical school, the first decision I had to make was whether I wanted to be a surgeon or not a surgeon. And that's one of the first key things. And when you go through your rotations as a third-year medical student, you spend time in various different areas of medicine. And you go to pediatrics, and you do internal medicine, and you do general surgery, and you do OB/GYN, and you get exposed to what it's like in those different areas, in the general areas of medicine. So I knew fairly early on that I enjoyed surgery. I thought it was quite fascinating. I enjoyed the anatomy, and as a surgeon, you're able to, I think, treat things a little bit more directly than the doctors who don't do surgery. So I decided that I was going to be a general surgeon. And the general surgeons at that point in the world had sort of a very broad area of work. And it involved everything from head and neck surgery to chest surgery to abdominal surgery. And so it was a very broad area. And intellectually, I thought it was quite fascinating. And so the way you get to become a general surgeon or any surgeon, you have to go through medical school. And then during medical school, towards the end of medical school, you apply for a residency. in that particular area. So I was at the Mount Sinai School of Medicine, and I was actually doing research during my summers in the Department of General Surgery. And I had published a couple of papers in national journals. It was very exciting on both breast and colon cancer. And they accepted 2 people into their general surgery residency from Mount Sinai, and I was one of the 2. And I thought that was quite fantastic. And to become a general surgeon after medical school, after 4 years of medical school, you then have to do 5 years of training. So it's quite long. And in my 3rd year of general surgery residency, a very close family member became sick with cancer. And I had been having some second thoughts about general surgery because there was so much cancer that I was dealing with that I found it somewhat difficult. And after a close family member became quite ill and didn't survive, I decided to switch to orthopedic surgery. And orthopedic surgery is what I consider or call it's a happy field. People generally are not dying from anything in the orthopedic world. And it's a field where you generally can make people better. And it encompasses patients really of all ages. We see pediatric issues, I see a lot of adolescent problems, and I see patients in their 20s, 30s, 40s, 50s, all the way into their 90s. And there's a whole different, as you can imagine, spectrum of problems that I see based on patients' ages. So what really drove me when I switched from general surgery, orthopedic surgery was a field where technology was having a great impact on what we could offer people when they came to see us with a problem. So many years ago, the orthopedic surgeon basically just dealt with broken bones. And that's basically what they did. And that was okay, but not that exciting when you compare it to what we do now. And with the advent of technology allowing us to do many, many procedures with what we call minimally invasive techniques, like what we call arthroscopic surgeries, it's opened up pretty much a whole new world of treatment possibilities for people who come in with various issues. So my training, when I switched after 3 years of general surgery, I then did 3 years of orthopedic surgery, and then I did an additional year, which is called a fellowship year. And that was sort of extra training in an area that I specialize in, which is the shoulder. And my practice now is limited to just taking care of shoulder problems. So I am very specialized. And that also came about just because when I was doing my orthopedic training at Columbia Presbyterian in New York City, there was a world-known shoulder surgeon there who took one person a year for extra training, which we call fellowship, and he asked me if I was interested, and that's one of those things you don't turn down. And so that led to me becoming a specialist and really an expert in the world of shoulder problems. So I'm currently in a group practice in Greenwich, Connecticut, and it's a group that I helped put together in 1998. And we started out with 9 doctors, and now we are 22 doctors. And we continue to grow pretty much every year and adding new physicians. And in this group, and this is why probably the majority of orthopedic surgeons practice is in what we call a group practice. And there are still a few doctors around the country who are in what we call solo practice or by themselves, but it's really very, very few. And there are many advantages to being in a group, which I probably can't go into here, except for me, the big advantage for me was that when you're in a group, you can really specialize because you have lots of other doctors doing everything else that didn't interest me as much as the shoulder. So on a day-to-day basis, what I do is I spend probably 2 days a week seeing patients in the office and 2 days a week doing surgery. And most of the surgery I do now is what we call outpatient or ambulatory surgery. So that means patients come in the same day, I do the surgery, and they go home an hour or two later. And that's also been a big change in the world of orthopedics as the technology has gotten better, where we do much less invasive type things. We can do many surgeries with the camera now, which is the arthroscopic surgery, whereas years ago we used to have to do open surgery, and that means we used to have to make an incision and open up a joint to correct whatever the mechanical issues are, or something that was torn or needed a repair. So most of the procedures I do are arthroscopic. The ones that are not arthroscopic is an operation that's known as a shoulder replacement. And you may have heard of people having a joint replacement. And the most common joints that are replaced are the hip and the knee. And we do surgery for people who develop typically arthritis. And you get arthritis generally as you get older, but it can affect people in their 40s, as young as their 40s, but most typically patients in their 60s and 70s who develop pain in a certain joint and they can't use it and they're very debilitated. So now we have the ability to essentially give them a new joint, which are new surfaces that take away the pain, and they have excellent function. So that's the only surgery that I really do that is not outpatient, because they stay 1 or 2 nights in the hospital. Or if someone has a bad fracture of their shoulder and we have to go in and put the pieces back together, and we use things like plates and screws and pins, and we can put bones back together, and so people can then heal and recover from significant fractures. So that's a lot about orthopedic surgery. Has that generated any questions before we go any further? Amanda, anything you want to know?
I just wanted to say that it's interesting how orthopedic means not just the foot or the knee, because before that's what I thought it meant, but now I didn't know it's muscle, tissue, and bone kind of field, right?
Yeah, a lot of people have that misconception because there's a field called podiatry, which is study and treatment of foot and ankle problems. But orthopedic involves the entire body, and it involves all issues, not just bone, but it involves the entire musculoskeletal system. And you do need a good background in medicine because there are a lot of medical conditions that affect either muscles, tendons, or bones. And so you really do need a good background in medicine, and that's why you're required to go through full medical school and then another really 5 years of training. Because occasionally we see certain tumors that involve bone, or we see metabolic problems, we see people with osteoporosis, we see people with thyroid issues, and so you really do have to have an understanding of general medicine, but orthopedics by itself encompasses all those areas, so it's far more interesting than just taking care of the foot. Hannah, anything that comes to mind?
Not that I can think of right now, but if I have a question.
And we have, is that Catherine?
That is Catherine. Hi, Catherine.
Hi, Catherine. How are you?
Oh, we can't hear her. Can anybody else hear her?
Catherine, is your volume on? No. Okay.
Let me see here.
So we can't hear Catherine. All right. So there were a couple of questions. Let's see. Amanda, you had asked what is the most common orthopedic procedure. So the most common is probably what we call arthroscopic surgery of the knee. And again, arthro means joint, and scope is a scopic for scope. And that involves using a very small camera. It's about 4 millimeters. And we put that camera through a very tiny incision into the joint. And that allows us to see all the structures and identify problems. And then through another little separate incision, these incisions are probably 4 or 5 millimeters, we can put in little tiny instruments. And we watch the whole thing on a big high definition TV screen or a monitor. So we're working with 2 hands in a joint, but we're watching on a screen. And that arthroscopic knee surgery is probably the most common orthopedic procedure. The other thing that's probably second after arthroscopic surgeries, and we do arthroscopic surgeries not just of the knee, but on basically any joint in the body. So shoulders, elbows, wrists, fingers, hips, knees, and ankles all can be arthroscoped. And there are different size scopes. They go down as small as 1.5 millimeters. They're very, very tiny, that we can look into the smallest joints and correct problems. And again, that's technology that's been developed really over the last 15 to 20 years, and even in the last 5 years, it's improved greatly. So does that answer your question on that issue?
Yes, thank you.
Okay. Hannah, you asked, what are my feelings or thoughts about medical school? So I think if you've decided that medicine is a great career choice, then obviously you have to go to medical school. Or there's another way to become a doctor, which is called a DO, or Doctor of Osteopathy. And it's not as common, but there are people who go that route who also actually practice medicine, though they go to a little different training. But the vast majority of people who go through a medical school. The number of applications for medical school continues to rise, and I believe the number was in the 45,000 or something last year for, I think, close to 20,000 spots. So it's still quite competitive, but I think it's a great choice, and I encourage it. There are a lot of issues these days about government and insurance and regulation and all that, and it has made our lives a little bit more difficult in terms of what we have to do with paperwork and things like that. But nevertheless, if it's something that you identify as a passion that you really want to do, then I highly encourage it, and I think it's a very rewarding career. I mean, I look forward to going to work every day. There are many people who don't in other areas. Every career choice and whatever you do, there always has its moments, but it's extremely rewarding. And every patient brings on different challenges and different issues. And I've been doing it for 25 years now, and I still look forward to it. So I think it's a great choice. Catherine, can you hear us?
No, we still can't hear her.
Still can't hear her. So her question was, hopefully she can hear me, what is the most common surgery? How long does it take? That I do. So are most of my patients athletes? So the most common surgery that I do as a shoulder specialist is known as an arthroscopic rotator cuff repair. And the rotator cuff, which you may or may not have ever heard of, is a group of muscles in the shoulder. It's 4 muscles in the shoulder that help you lift and move your arm. And it's a very common problem or injury when people, quote, tear, unquote, the rotator cuff. And what that means is that the way any muscle attaches to a bone is by becoming a tendon. And the tendinous attachment on the upper arm can tear off the bone. That's what a rotator cuff tear is. And what I can do is, by putting a little camera in the shoulder, I can take that torn tendon and repair it back to the bone. And I do that by using very small 3 or 4 millimeter plastic anchors that actually go in the bone. And these anchors actually dissolve. It takes 1 to 2 years, but they actually go away. But the tendon will heal back to the bone in about 6 weeks. And so I can take this torn tendon, which can be quite debilitating for patients. It's painful. They can't play sports. They can't sleep. And they're really quite unhappy. And in a procedure that takes me typically about 45 minutes to an hour, I can repair it for them. So that's the most common procedure that I do as a shoulder specialist. are most of my patients athletes? I would say that many of my patients are athletic. I spent some of them, or many of them, are what we call weekend warriors, who spend a lot of time on the weekends doing sports, but not so much during the week. I did spend about 9 years working with a professional baseball team, the New York Mets, where I was one of the team physicians. And taking care of professional athletes is somewhat different and brings on different issues than taking care of what we call recreational athletes. So, but the answer to the question is many are athletes, but certainly not all. And for rotator cuff tears, for example, probably at least 50% of the people I see don't have an athletic event or don't even have an injury, and the tendon can just tear. So, but being an orthopedic surgeon, obviously we do take care of a lot of athletes. We cover many of the high school teams in the area, and it certainly brings some people who have an interest in sports tend to maybe think about orthopedic surgery as a career because you are involved with athletes. And within orthopedic surgery, although I'm a shoulder specialist, there are doctors who specialize in what's called sports medicine. And they do a fellowship or an extra year just in sports medicine. And so some of what I do is it overlaps with what they do, but that is a recognized subspecialty within orthopedics. And I should just comment, medicine becomes very specialized. So I'm a shoulder surgeon, but we have good doctors in my group who just do hand surgery. We have doctors who just do spine surgery. We have doctors who just do foot and ankle surgery. And we have doctors who just do hip and knee replacement surgery. So even, as you drill down into a field of medicine that you're interested in, there become increasing options if you want to be specialized in an area that you find very interesting. It's not required, obviously, but many people do it really out of interest. So I hope that answers that question, and I'm happy to answer anything more. Or if Mr. Rusko, you think there's anything else we should talk about? Happy to do it.
Well, I want to make sure that everybody caught the fact that you said when you drill down to figure out what your specialty is going to be. As an orthopedist, I found that way rather amusing that you would drill down to find out.
You caught on.
Oh yeah, no, I'm here. I'm watching. Mike, I have a question. When I was doing my third-year rotations, I spent a bunch of time on orthopedics at the VA hospital in Denver, and the measurements that were taken for a replacement, mostly knees.
Yeah.
It was a lot of math on paper. I was amazed at the measurements they were doing. They had a PA in the practice that did nothing but that, just did measurements all the time on extension and flexion and strength and angles and coming up with, and then doing measurements on the outside with calipers to figure out what the replacement should look like. I'm wondering in your practice, that was 20 years ago. I just realized how old I am. I'm wondering how much computer assisted imagery is used in your practice, not necessarily just shoulders, but anybody at ONS, to determine damage, to determine likely course of action, and then especially I'm curious about replacements, about whether the measurements are done all by computers now, whether or not there's a lot of hands-on measuring with pens and markers and pencils and rulers.
Right. So that's actually a great question. So I finished my training in 1989, and in the 1980s we were doing a lot of what you said, meaning we would put these big x-rays up and we would take out various compasses and devices to measure angles and draw lines and try and figure out what needs to be corrected and what kind of cuts we need to make to put in a new joint. So that has evolved now. We use computers in a number of ways. We use computerized imaging, such as CAT scans, which is a computerized x-ray, and we also use MRIs, which also really involve computers, in order to get the proper images of bones and joints to determine what we need to do. On top of those computerized images, or even some of the plain x-rays, they've all become digital now, or pretty much all. So it's rare, I think, to go to an orthopedic practice and still walk away with the old-fashioned x-ray films. So everything we do now, and actually for the last 10 years, has been digital. So what that means is when we take an x-ray, and girls, you may have never had an x-ray, but what we used to do is expose an actual film, and the film would have to be put into a developer in a dark room and develop that particular piece of equipment within a couple of minutes would actually develop the film, and then we'd have to look at the actual piece of the picture. So now what happens is you go get an x-ray, and the x-ray technician, instead of exposing a cassette or that has film in it, it's electronic. So they put that cassette now in a machine, and that delivers an x-ray to my computer wherever I am seeing the patient, where I can look at the image on the computer. So that's known as a digital x-ray. And if you want copies of your x-rays, generally they're put on a CD, and you walk out with a disc, and you don't walk out with the actual films anymore. So in terms of technology, that was a big step, but that then allows us to do what we call digital templating. And there are software programs now that have been designed for actually a number of years where we can, on the computer, put angles or lines or actually use software programs to come up with all the information that you saw people doing manually. And I'm actually involved in some research on a software program for shoulder replacement that will give doctors better information as to what type of prosthesis would be best for that particular patient. And that's actually a new product that it's not FDA approved yet, but I'm working on it with some people from Europe. So technology has been a tremendous boon to helping us, not only in planning the surgery, but actually in doing some of the surgeries. And not that much in the shoulder yet, but particularly in the knee, the guys in my group at ONS who do knee replacement surgery do this all with what they call computer guidance or computer navigation. And what that means is in the operating room, they put these little sensors in various spots around the knee. And then through a computer, they can determine exactly how much bone should be removed and make sure that they're doing or making the cuts or the angles exactly where they should be, and it's confirmed by the computer before they do it. And that's relatively new over the last few years, and it's being developed for the shoulder, but we're not doing it in the operating room yet. And they do it for neurosurgery as well. They've used computer guidance for probably the last 5 to 10 years.
Great.
So it's been very, very, very helpful.
Terrific. Catherine, you want to give this one more shot?
Hello.
There you go.
There's Catherine.
Catherine's back. Okay. All right.
Hi.
Now, Catherine, where are you and what grade are you in?
I'm a sophomore at the Westminster Schools in Atlanta, Georgia.
Oh, so you and Hannah Ruth must know each other, yes?
Yes,
Okay.
we do.
Okay. I'm curious from GOA's perspective, are you guys in the same section?
We are.
You are not. Okay, all right. I figured that wasn't going to be the case because we try to avoid that, but that's just my curiosity. Catherine, do you have any other questions for Dr. Miller?
Not that I can think of.
Okay.
Well, I would just like to close by encouraging you guys to really to look very carefully and try and expose yourself wherever you can to medicine. I was fortunate to take my daughter, who's a senior in high school, on a trip to Haiti, where we did some mission type work down there for patients who really needed help but couldn't afford it, obviously, in that country. So there are options to get exposure to medicine. You have to sometimes be a little aggressive and look for them, but I encourage you to do it. I think it's a wonderful field, and I hope you guys will consider it.
All right. Any last thoughts, ladies, or are you guys all set? I'm seeing nothing. Can everybody hear me? Okay, all right. All right, then what I'm going to do is this. I want to thank Dr. Miller on behalf of GOA and Medical Problem Solving